The purpose of these talks is to reach out to the public and try to educate folks on how the kidney works and kidney disease, and to address any questions or misconceptions you might have. So welcome everybody to our May 18th, 2023 meeting, and I'd be glad to take any questions you might have and help you in any way. So Bernard, do you want to go first?
Yes, thank you so much. And I first want to thank you for devoting your time like this. It's very much appreciated.
My pleasure. My pleasure.
So I have it's a paired question. The first one is, I've seen a lot of TV ads about Farsiga and heard something. I wonder if you have some comments on the efficacy of that and data. Yes. And the related question is, we know about very serious interventions, replacement and but what are the other options that are less serious, that are simple, like Farsiga? What other choices are there when there's some problem that you'd want to intervene?
Yes. Do you mind just maybe discussing a little bit about your background as far as health? Or
Sure, I didn't want to make it too personal, because there's other people.
I understand.
But I'm happy to do it. First thing, I'm 88, and I realize what the kidney aging function looks like. You showed that in one of your lectures.
You sound like you're 40.
Well, I don't feel like it. So I've had a high, I'm probably mispronouncing it, creatinine count. It was years ago, 20 years ago, 1.5. And now in the last...
You're talking about your creatinine?
Yeah. And now in the last decade, it's slowly crawling up. Now it's about 2.2. Yeah. So I'm getting concerned about what the future looks like and what interventions I can undertake.
Yeah, so for those that aren't familiar, just to reiterate, the creatinine is the blood test that we typically take. It's a very common test. When the doctor measures your blood, typically they will get a number of things, but one of the measurements is creatinine. And creatinine is a reflection of kidney function. It's made in muscles, and the kidney gets rid of it. And the production rate from all the muscles is equal to the rate at which the kidney gets rid of it. And for technical reasons, because parts of the kidney don't absorb it or take from the blood and put it into the nephron, which is the sort of the tubular part of the kidney. Remember, the kidneys have filters and then a tubular part after the filters. Because the tubular part does nothing to creatinine and it's only filtered, it's felt to be, for many, many years now, over half a century, one of the best ways to assess how well the kidney is filtering fluid. And typically people don't say those words per se, they say what your kidney function is. And that's not the best word, because the kidney has many, many functions. One of its important functions is the filtration of fluid or of water. And so the creatinine is a very nice assessment of that in most situations. Now, the way you can think of it is, if the creatinine is 1 and your kidney function is 100%, then when the creatinine goes from 1 to 2, your kidney function approximately goes to half of what it was originally. And when it goes from 1 to 4, the kidney function is now a quarter of what it was originally. It turns out that you can lose 90% of what we call kidney function. Again, it's not the best word. It should be the ability of the kidneys to filter water. You can get down to 10% of your original level, or the so-called normal level. Until then, you don't need what we call renal replacement therapy. Once it reaches about 10 to 15% of its original value, then we have to do something. We either give you a transplant or put you on one form of dialysis or another. What was brought up by, is it Bernard? Can I call
Yes.
it Bernard? Was this aging effect. And I've shown that in previous slides or lectures where we were showing slides where it's not well appreciated, but the creatinine tends to go up as you age after the age of 50. And that's because the normal aging process affects the ability of the kidneys to filter water. And it's not widely appreciated that if you start off, let's say, at 100% in your 30s and 40s, it's not going to be 100% when you're in your 80s or 90s, unless you're an exception to the norm. A typical human being loses the ability to filter normally after the age of 50 or so. And so the doctors really should know that, because that becomes the new norm. We don't consider that a disease. We don't consider that an abnormality unless it's worse than that normal aging caused loss. So the question is, what should it be in your 80s and or mid 80s and 90s? And it can go down to about 65% of that original level. And that's not called CKD or chronic kidney disease like we would if it happened in a 30-year-old. And it's not considered an abnormality. And it's now felt to be something that you don't need to worry about as far as consequences. If it's less than that, then you have an abnormality that needs to be worked up. But a lot of people in their 80s and 90s are being worked up for no reason, because most doctors, or many doctors at least, aren't aware of this normal aging effect. So,
Doctor, what number would that be then?
Well, if you look at the curves, it's like 65% of normal. Now, the question is, how do you translate that to a serum creatinine? Or what now has been for a number of years now appearing in the lab reports is something called your eGFR. The eGFR is, the E is an important letter because E stands for estimated. GFR is a very fancy technical way of saying how much your kidneys are filtering as far as water. And so, and the GFR is an acronym. It stands for glomerular filtration rate. Glomerular because each of the filters is called a glomerulus. And you have about 1 million in each kidney or so, depending on if you're a man or a woman. Women tend to have less filters. So what it refers to is the total filtration ability of your glomeruli. And it's estimated. It's not a measurement. It's estimated because the way the lab does it is they take your creatinine measurement, which is a measurement. In your case, I think you said it was 2.3 or something.
Yes.
Point something, and they put that into a formula, and there's a whole bunch of formulas, which I won't get into now, but these are population-based formulas where people actually did measure the true glomerular filtration rate with another technique, and then compared that to the formula to see how good they can create the formula, which is just a prediction. So you have to realize that the eGFR, and it's something most people don't realize because it's become so widespread, it's in every lab report in every hospital. People think that's a real number, but it's not. It can be off by 20%. So the sequence is you take this real measurement, the creatinine, you plug it into this formula, and the formula spits out an eGFR that can be off by 20% from the true filtration rate. Now, that filtration rate, including your eGFR, will decline as you age. And so when we show those graphs of what the GFR is doing with age, those are true measured GFRs. Those are not eGFRs. We don't, you might ask then, why don't you just measure the GFR in every patient? Why are you giving us this surrogate, the eGFR, if it's also an estimate, which can be off by such a big percentage? And the answer is the historic way of measuring the GFR that we used to do in the 60s, 70s, and 80s was a radioactive method that just fell into decline. Number one, because it's a radioactive substance that needs to be injected. And when the formulas came out, they just sort of took over because people were, I would say it's a human emotion more than a logical thing. That is just nicer to plug in a creatinine into a formula and get a GFR rather than to make the patient go through a technique where you have to inject something into the vein, wait for the measurements to come back, you're injecting something radioactive. Again, nothing dangerous, it just, has its own stigma. We are working at UCLA with others on a way of measuring GFR again. So we're going to wind the whole clock back 30, 40 years. And hopefully that will take over and eGFR will be a thing of the past. So that's sort of a long-winded way of just going over the two lab tests that people use to assess the amount of fluid coming through the kidneys. Again, when it's the 10% of normal, 15% of normal, that's when you have to start worrying. 50% of normal, 30% of normal. We don't do anything other than monitor it. We try to, of course, figure out why it's going down, and the goal is to keep it from going down further because we don't want it to get to 10%. We have different things we look at and different drugs to use. We don't have a magic drug yet that in all patients can stop a decline if we're seeing that actually occurring. That's one reason we follow up people who have creatinines that are above normality or eGFRs that are below what they should be, because we don't want that to get any worse. Many times there's nothing we can do about it, but depending on the cause, there are things that we can give to slow down that decline. Typical things like looking at blood pressure, making sure the cardiac function is good. If there's a lot of protein in the urine, we try to decrease that because there's some evidence that just having a lot of protein in the urine, which came from the filters of your kidney, the protein gets into the urine because it's abnormally filtered. It shouldn't be coming out into the urine. We try to decrease that because there's some evidence that can damage the pipes or the tubes coming after the filters. And there's a number of other things that can be done to try to decrease a documented worsening of the ability to filter. You'll hear all doctors just call that your kidney function, but remember what they're referring to is the ability to filter water. And the normal kidney can filter about 120 liters a day, both kidneys. So if you imagine what a 2-liter Coke bottle looks like, imagine filtering 70 of those through both kidneys every day. That's what comes through the filters. And yet you only urinate 1 liter or 1 to 2 liters. So when you think about it, 120 or 130 liters is coming through both kidneys, but in the tubular part of the kidneys, you're reabsorbing back into your blood about 118 of those liters, so that you end up only peeing out 1 or 2 liters. Just an interesting thing to think about. Obviously, you're not urinating 120 liters a day. You'd pass away very quickly, since you only have about 5 liters of blood. So it would be, and if you think about it, the blood is filtered over and over again. That's how you get your 120 liters. You only have, you have 5 liters of blood, roughly 2 liters of which is 2.5, 3 liters of which is fluid. The rest is the cells that make up the blood, the red cells, the white cells, and the platelets. So you've got about 3.5 liters of fluid in your blood vessels, and yet you're filtering 120 liters. And that's because that fluid is filtered over and over and over again throughout the day, of which you get rid of 1 to 2 liters, depending on how much you drink. So it's the filtration of the kidneys that we care about the most. Now, as the filtration declines, you also lose the ability to do other things that the kidney looks after, and that is to get rid of potassium, to get rid of sodium, to get rid of other what we call electrolytes in the blood. Gradually gets worse and worse as the filtering ability gets worse and worse. And you can imagine that's because there's less of it going through the filters. There's a greater chance of things accumulating in your blood. So we also look at those things, and they start to build up at different impairments of filtration. Initially, even with impaired filtration, the kidney works out ways of keeping the excretion of those things normal, because the tubular part starts to take over as far as taking stuff from the blood and putting it into the urine. It doesn't have to only come through the filter. It depends what substance we're talking about. So as far as yourself, you have a creatinine of 2.3, I think it was. One of the things we'll look at is, are you very muscular? Because as I mentioned, the creatinine is made by the muscles. And so athletes can have a creatinine of 1.3, 1.4, 1.5, just because they have so many muscles that are making it. And there's nothing wrong with the kidney. The other source of creatinine is in the meat you eat. So if you're a huge meat eater, because creatinine is in muscles. So it doesn't matter if it's your muscle or the muscle from a cow, which is the meat you're eating. So if you're eating a lot of meat, your creatinine can also go up, at least transiently, from the food you're eating. So in general, we like all blood tests to be done when you're fasting. I know people are familiar with it when you get your lipids drawn, your lipid panel, but the reality is whenever your blood is measured, it should always be fasting. And the reason for that is if you eat, you're going to be perturbing a number of the things we're trying to measure. And if every time you get your blood drawn, you're at different time points from a meal, that can alter the results. Whereas if you're fasting, at least the component of dietary effects on the blood test won't be there. And so it's always better, even if the doctor doesn't tell you to get the blood test, always fasting. Then you never have to think about it. And then the results are more comparable. And the only thing affecting it would be some endogenous process going on independent of your diet. So just as a general rule, always get your blood test done fasting. Don't even think about it, which means you got to do it early in the, it depends when you want to eat. Some, people can go for different lengths of time without eating.
Mm-hmm.
So getting back to you, 2.3 is a bit above normality. It depends on your estimated GFR. What are you getting back from the lab test? Do you know what your eGFR is? It probably is coming back.
I think 430 or 450.
It would be, well, that 450 would not be a number for the eGFR. It would be more like, it's something between 0 and 100. So it likely is coming back in the 30s or 40s. But again, more importantly is what you mentioned, that it was this number 8-9 years ago, and it's now this number. Again, it's the rate of change and what it is. I don't know if you're seeing a nephrologist. I can't recall from the previous calls, but you probably should be seeing one, just to track your numbers and make sure that it's staying around 2.3 or in the low 2s. Again, if it goes from 2.3 to 2.4 or 2.2, that's not a significant change. You're looking more for things like 2.3 to 2.8, that kind of thing, or 3, or the converse, if it goes from 2.3 to 2. So it can fluctuate too. People get hung up about the decimal, which is not worth doing. It's more the trend. And so if every year it's around 2, 2.3, 2.2, 2.4, don't worry about anything. It's important when you have abnormal kidney function, and I would say yours is a bit abnormal, not horribly for your age. It's a bit abnormal to make sure your blood pressure is well controlled. But you also have to be aware that certain blood pressure pills can raise the creatinine and because they make the ability of the kidney to filter a little bit worse than it has been prior to starting the pill. So there's always a toss-up. It's not sometimes, and most of the time it's reversible. You just stop that blood pressure pill and then the creatinine comes down again. So in a given patient who has an elevated creatinine, what the doctor should be doing is going through all the known causes of an elevated creatinine, which are either some endogenous process independent of the doctor or the patient, or a pill you're on. It's always the same thinking. So you go through all the pills and you see there are certain pills to avoid too. As I always mention, you want to stay away from the non-steroidal anti-inflammatory agents like ibuprofen and naproxen. because they can damage the kidney and they can do it permanently. And many people have gone on to dialysis or gotten a kidney transplant because they had chronic back pain or knee pain, athletes, and they're taking a ton of NSAIDs throughout their life. And if you take them in enough dose and long enough, you get permanent damage of the kidneys, damage to the point where you need what we call, again, renal replacement therapy, dialysis or a transplant. So you have to be careful about the pills that can damage the kidney, even if you're not taking them, when you have some underlying kidney issue, just to make sure that you're not exacerbating or making the problem worse than it would be otherwise. And you just have to also try to not get into the hospital altogether or have any severe illnesses that can potentially impair the kidney, because, for instance, you can have some underlying kidney abnormality, everything is stable, you're fine. But let's say then you, I don't know, take a horrible scenario, you have a heart attack or you get a severe pneumonia and you have to be hospitalized. Well, typically things are done in the hospital that can affect your kidney function, like putting you on antibiotics. Many antibiotics can damage the kidney, or some people need dye for an x-ray, either let's say an angiogram to look at the arteries around your heart, or other types of imaging. They'll give a radio contrast agent, and those things can affect the kidney also. In addition, just to severe drop in blood pressure or severe infection can affect the kidney. So you want to stay healthy outside of the kidney issue and stay out of the hospital. And in addition, you want to keep your heart in general in great shape, because if you have a very good heart and your heart's in great shape, it perfuses the kidney with blood efficiently, and that in and of itself is a great thing, because people who, and then the sort of the other scenario where people who are on dialysis who pass away, it's usually not from the kidney, it's because of heart complications. They tend to get abnormalities with the arteries in their heart, and that can then lead to angina, or it can lead to problems with heart function. And then you get this secondary effect of not perfusing the kidney. Normally that isn't an issue if you're on dialysis, but having an abnormal heart per se can be a cause of death. So whether you're on dialysis or not on dialysis, the cardiac care that you get is essential to living a long life. People don't die from kidney failure or being on dialysis per se. I mean, the dialysis has replaced the kidney function, not perfectly, but to some extent. And so it's the cardiac issues that lead to the majority of the problems. So just in general, a cardiologist and cardiac care are fundamentally of primary importance to living till 150. So I don't know if that answers your question. I think you had a question about Farsiga. That's, for heart failure. If that's what you're asking about, that's for people who have an abnormal what we call ejection fraction, which is, you can think of it just as how much blood your heart is pumping every time it pumps. Well, as the heart doesn't pump as well, the amount of volume being pumped out per beat decreases, and there's different stages for that and gradations, but in general,
so it's not a kidney intervention.
Farsiga, no, it's heart.
Thank you. Yeah. Thank you. Well, my kidney person put me on a Farsiga.
Okay, well, I think, well, it depends. I mean, it's used for both. So it depends really what's going on. So Farsiga also helps the heart. And, it helps the kidney too. It's one of these drugs that helps both. I guess in your case, if there's nothing going on with the heart, then it's probably for the kidney. The problem with these drugs typically is that if it's for the kidney, the doctors don't leave patients on it long enough, they tend to stop it, because when you first start these kind of drugs, the kidney function can actually get transiently worse, but then it comes back down again. So the trick is to keep people on it for a long period of time. And yes, it seems to be a drug that can slow down the rate of worsening of underlying kidney disease in many different patients. So it's a good drug, but you need to stay on it. And in a given patient, you don't know.
Right.
You'll never do the experiment of knowing whether the kidney function would have taken the same course without it.
Right.
You know, you can't do an experiment saying
Right.
what would have happened without it. You can only compare it to what happened prior to starting it. And that's assuming that the rate of change is going to remain the same. That's a guess. But at any rate, it's a good idea to be on it, because you do have some underlying something going on in the kidney independent of the age. Not horrible. And so the doctor should not be attributing the entire increase to 2.3 to some underlying kidney issue. There's a big age component there too. And to assign percentages is impossible to say. But the goal should be just make sure you're always aware of what your creatinine and your EGFR are, and make sure that they're staying, that at least if you forget the EGFR, no, just be aware that your creatinine should stay in the low twos. And if it does, you're going to live a long, long life as long as you look after your heart.
Right. Thank you so much.
Does anybody else have any questions that I can help with? Oh, hi, Richard.
Yes. Hi. Thank you, Dr. Kurtz, for this. It's very informative.
Oh,
Yes.
great.
I had a biopsy on my kidney,
Okay.
and they find that was in February this year. I'm 82 years old.
You all
And
sound so young. I mean, or I'm losing my hearing or something. Okay. Why did they do the biopsy, if you don't mind saying?
They found an indication in a biopsy in a MRI I had several years ago, and this was an accidental find from that biopsy.
So they saw something on the MRI years ago?
Yes, years ago, and then eventually I had a MRI to look at the kidney. I've had several of them.
Okay. Do you know why they were looking at your kidney? Were you complaining of anything, or did they notice anything?
No, nothing at all. It had to do with some nerve problems I was having in my back and shoulders.
Oh, I see. So
Initial discovery of the mass in the kidney.
When was that? What year?
That was quite a while ago. It was maybe 3 to 4 years ago.
Okay, so they saw something in the kidney, and
yes,
you know if it was left or right, or
the right.
okay.
So I have the
did they take a biopsy of that at the time?
Not at the time. They have had say 2 or 3 MRIs.
I see.
On
so
the kidney.
They just followed it over time. They decided not to do anything, just to watch you, and they've been taking MRIs since. And how have you been over the last 3-4 years? Have you had any symptoms from it or anything, or is it just an incidental finding on an MRI that they want to follow until the recent?
It was an incidental finding. And then I did have eventually I had last February I had a biopsy.
Why did they decide to do it? Was it changing in size? Did it look
was changing in size.
Bigger or smaller?
Bigger.
And okay. And you had no blood in the urine or any other abnormalities as far as creatinine or anything as far as lab tests? Just a change in size of this.
Creatinine is in the normal range.
Okay.
And I have
no blood in the urine that you know of?
Not that I know of. I eat a lot of beets.
Yeah, that's
And-
always an issue.
And so occasionally I quit eating beets to
Yeah,
make sure that I'm not bringing up blood.
Yeah, we teach the students that because so one of the common problems in the clinic is someone will come in and say, you know, I was fine. I woke up Monday morning and I peed, you know, red. You know, my urine was all red, and I thought I was bleeding. And the first question a good doctor should ask you is, did you have beets the night before? It can make the stool red too. So so you know, you go to the bathroom and you have stool come in the toilet, and the toilet's all red with stools. It makes people think they have colon cancer or something. So it can be either end. And so, yes, I mean, your urine could be red, but the difference is when the urine is looked at under the microscope, there's no red blood cells there. So if we suspect someone has blood in the urine, we divide that up into macroscopic and microscopic, what we call hematuria. Heme means blood and uria means urine, hematuria. And if it's not grossly red or pink, we still look under the microscope to see if there's red blood cells there to pick up more subtle bleeding. But in your case, the beet seems to account for things. So you had the biopsy, and what did that show?
It showed a papillary renal cell carcinoma.
Okay. And what did they decide to do about it?
And so I enrolled in this histotripsy trial that's coming to UCLA.
Hmm.
That won't be until that trial won't occur until, or say, late summer or fall.
Did they tell you what they thought would happen diagnostically, or what would happen if during the trial, or what the trial is? I'm not familiar with the trial. What kind of treatment is that?
It's a non-invasive
Okay.
treatment. It uses the bubbles in the blood, focuses, it uses a sonar.
Oh, it's ultrasound.
Yeah, and uses those that it uses the bubbles in the blood to expand and contract the bubbles, and it'll destroy the tissue that it focuses on.
Yeah, typically, I mean, what will happen with different types of masses that are more dangerous in the kidney is sometimes they'll take the whole kidney out. Again, this is urology, not nephrology. Nephrology are doctors that don't do surgery on the kidney. Urology are the surgical people that they get involved. But at any rate, so we don't really look at kidney cancer here, nor in any other institution. It's looked after by urologists. But there are several approaches, and again, there's many different types of masses in the kidney, from ones that are what we call benign, where they're just there, they don't do anything. They may grow, they may shrink, they're just followed, to very severe cancers of different types. And if the doctor decides they want to take it out, they may take the whole kidney out, depending on the extent of it or how much it's spread outside the kidney capsule, or they may take a part of the kidney out. It's called a partial nephrectomy. Or they may not do any surgery and use what's called radioablation, where they put radio waves into the mass and they basically burn it. But there are many other research projects ongoing. One of them, I guess, is to do this. I guess they have a way of focusing that so it doesn't, because what that's going to do is these bubbles, if they are created, will stop blood flow. It sounds like that's what's being done here. The bubble is in the blood vessels. So, you know, it's like when you get the bends, when you come up from deep sea diving, you get all these bubbles of nitrogen coming out of your blood. And the reason you get problems is it blocks blood flow. It doesn't matter that the blood vessel itself is open. If you create a bubble inside a blood vessel, blood can't get to the tissue. So it sounds like the same thing they're doing here, where they're intentionally trying to create bubbles that are going to be blocking the blood vessels that will then kill off the mass. I guess they have a way now of targeting it so it doesn't kill off the normal kidney tissue, which is always a problem with these kind of things. And that's why people are working on ways of not taking out the whole kidney, because when you take out the whole kidney, your creatinine immediately goes to 2. You've lost half of the ability to filter water. So, and and it depends on whether the second kidney is normal or not. If it's not normal, your creatinine even goes higher. So there's always this goal in general of trying to save kidney tissue and have the greatest number of filters as possible, and not remove ones that don't need to be removed. Because if you have a mass in your kidney, the mass isn't everywhere, and when you're removing the kidney, you're taking out normal filters, which is a shame. So it seems to me this is analogous or along the same lines as the radio ablation, and doing it in a way that's non-invasive, because the radio ablation, they have to go into the kidney. This way they can do it from outside the body, where they target the ultrasound in such a way that it will only block certain blood vessels. So that's pretty amazing that they're doing that. When does the trial start?
As they expect it in late summer, early fall, I believe.
Okay, I mean,
I'm having another MRI in July.
okay. Well, it doesn't sound like they're too much in a rush.
Well,
if they're willing to wait enough to do this trial, which is a good thing.
one thing is that I have the mass itself is like 2.8 centimeters.
Okay.
And the limits on the trial are 3. It can't be over 3 centimeters.
So you're getting there. You're getting close.
So I don't have much room.
Right. Well, do you know what rate it's growing at? I mean, it should be. It doesn't have to be linear. By linear, I mean that it's increasing in size the same amount in the same period of time. That's what linear means. So like every month it would increase by whatever 2 millimeters, whatever the number is.
Yeah.
That, in the next month 2 millimeters, the next month. So the same size change in the same time period would be linear. Do you know if it has been, or did it suddenly increase in size, or that's just not known?
It's been a gradual increase in size as measured on the MRIs.
So do you know how much it goes up every 6 months in centimeters?
It's a little hard to tell. It looks like maybe
A centimeter is
0.4, 0.3.
if you look at the thumb, it's about a centimeter, the nail.
Yeah, it's about 0.4, maybe centimeters.
So about 0.4, 0.5 centimeters in what period of time? How many months?
And, I've been having them once a year.
So it's about so 0.4 centimeters in 12 months. So that's, let's say, I'm trying to calculate each month, because you've got how many months left? 2 or 3?
Probably 3, yeah.
So in 3,
At the most.
It's maybe go up 0.1, 0.1. I mean, I think you'll make it.
Yeah.
You're going to be close, but I think you'll make it. And I can't believe, if it's 2.05, they're going to say you don't qualify.
Yeah.
Even,
That's why I was wondering how hard and fast this 3 centimeter.
right. You just have to press your stomach in to shrink it a little.
Okay.
No, I think probably it'll be fine. I mean, do you know if you're definitely going to get it? Because sometimes there's a control group where they do something else and it's not the real procedure, and the doctor's blinded to it. I don't know if they're going to be doing that, where they just turn the ultrasound machine on but don't actually make bubbles as a control group to compare it to. They may not. I mean, everybody getting the technique may get the real technique. It depends how the study is designed. But that's great. Who recommended this to you? And did they talk to you about not doing the radio ablation or the partial nephrectomy also?
It was recommended by my urologist.
Right, but did they talk to you about?
Well, he talked to me about the other options available to me.
They
There's
did.
a needle ablation
Okay.
or partial
And did they talk
operation.
about not doing that and what the downside would be of not doing the routine approaches, or they didn't get into that? Did they say that by not doing?
Well, this the matter of one consideration that came up was just that I live alone,
Mhm.
and the recovery process might be
Oh, I see.
difficult with a surgery.
Yes. Yeah, I mean, the nice thing about this is it's totally non-invasive, it sounds like, which means non-invasive means no surgery.
Mhm.
And likely the recovery time is going to be a lot faster. So in that sense, did they talk to you about anyone they've done and what the outcomes are and how well this works? Did they go over
There's
data?
there was a similar the same technique has been used on the liver.
Okay.
And that study has already been completed, and they had good results from the liver.
It's very exciting.
And
Yeah, once you have it done, please let us know if you feel like it, how you did, how things went. It'd be interesting to, but I'm sure, you're with experts here who, know what they're doing. And it sounds like, that you're going to get, in my estimation, as good a result as you would get with the radio ablation. And we'll see. But the nice thing is also, they can always do those other techniques if they need to. It's not like you only have this one option. You have at least another couple of options, it sounds like. The radio ablation and the partial nephrectomy. And if your creatinine is good, you don't have to worry about a significant effect on your kidney function.
Mm-hmm.
Even if they do bump off some normal tissue, you're probably not going to see a change in your creatinine, that's perceptible. So I think it sounds like this is the best approach. It does bring up the issue that we all have things going on inside our abdomens and elsewhere that we don't know about. And some people have talked about, why don't we just do a CAT scan of the whole body in every human every year? Women get mammograms, this sort of things, but why aren't we scanning the whole body every year? And although it makes sense as far as not missing anything, number one, it'll be very expensive to do that to the whole human population. And number two, we'll be seeing so many things that we didn't know about. We won't know what to do, because it brings up the general question altogether is, we see a mass anywhere, we see an abnormality. Should we do something? Should we not do something? And you'll be doing so many additional tests to figure out what these things are that are incidental, what we call incidental, which means they're not important, that it would just be overwhelming as far as doing a lot of inappropriate tests on people. But in general, it just brings up the issue that a lot of these things are found just incidentally, just because you happen to complain about something, or it's a very common thing where an MRI or CAT scan will be done and the doctor goes, oh, we see something in your liver, or we see something in your lung, or you had no idea anything was going on. So it also brings up the general issue that, and this is more philosophical in addition to medical, that there's a constant war going on all the time. And between abnormality and normality, your body's constantly, you have something, I can't remember how many cells are in the human body. It's like, I can't remember, 20 to 50 trillion cells, something like that. It's a huge number. I may be way off, but the bottom line is you have normal cells and abnormality happening all the time. And there's a constant war to keep you in the so-called normal camp. And that's going on all the time. So the fact that we don't see anything doesn't mean you don't have multiple attempts every day and throughout your body to make abnormality. It's just that the normal forces win out. So the lack of having abnormality doesn't mean you don't have abnormal things happening all the time. It's just that your body was able to, or the cells were able to counter the abnormal tendencies or cells or pathways that are occurring all the time. You only see abnormality when there was a war lost, where the normal forces could not counter the abnormal. But the lack of seeing abnormal doesn't mean there's not abnormal things going on every day. So you're in this constant battle from 0 to 120 years of age to try to keep things in the normal camp. So that's just something to consider. In addition to the fact that there's abnormal things popping up all the time that we'll never know about, just because we're not making the right measurements or imaging that area on an ongoing basis. You know, it's like your car. You don't know all the things happening in your car every day. You just assume it's good enough to drive. It's the same with our bodies. I tell many patients in the clinic, you look after your car better than you look after your body. So they sort of laugh, but I think that's true with a lot of people.
Oh,
And, you know, as you both know, when you're 10, 15, 20, you can throw any garbage into your body or, do anything to it. And the body has these backup systems that recover. But when you get to be 50, 60, 70, 80, 90, 100, your ability to do that is less. And so you have to be much more careful not to perturb the system if you can. But as I say, the kidney is not an organ you typically have to worry about because we have abilities to replace its function. It's the heart, the brain. Those are the two things you want to keep intact if you can.
There's another, I have a pseudogout, and I'm taking a meloxicam.
What's it called?
Meloxicam, Mobic.
Not familiar with it.
It's an acid.
Okay, pseudo gout is like gout, but it's not caused by uric acid. It's caused by other ions, calcium pyrophosphate, if I remember correctly.
Yes.
But is the compound you're on an issue because it can affect the kidney? Is that why you're?
Yes. Well, I was wondering what effect that will.
Can you spell the name? Can you spell the name of
MELOXICAM?
Oh, meloxicam. Let me see. It might be an NSAID, non-steroidal.
Yes, I believe it is.
If it is, then there's nothing unique about it as opposed to other NSAIDs. Yeah, it's an NSAID. They can all affect the kidney, and so you have to be careful as far as how many you take. They can also affect the stomach. Sometimes you get nauseous with it or little pain. It can create a stomach bleeding. It can irritate the stomach, so you have to be careful. They can also affect the heart. Again, and not to scare anybody. I mean, just depends how many you take and how often. Are you on a large dose? Are you taking them every day? Do you need
15 milligrams every day?
Well, again, if you're on an NSAID chronically, even if it's a smaller dose or whatever dose, just make sure you're getting your creatinine measured. The creatinine.
Yes,
how often? How long have you been on it?
I've been on it approximately 2 to 3 years.
So if your creatinine, if your creatinine has not gone up or changed over this time, and your dose has been that, and nothing has happened to the creatinine, then don't worry.
Yeah, it hasn't really affected the creatinine at all.
Yeah, just make sure you're constantly watching your creatinine. I mean, the two classes of drugs we watch out for are NSAIDs, and also in women especially who are worried about their bones. There's a lot of women taking Tums, and they can take a lot of Tums. Tums isn't just an antacid; it's got calcium in it. The antacid part is the carbonate. It's calcium carbonate. And the carbonate acts as the antacid, but it's calcium. And so people take it also for their bones or to make sure they get enough calcium. For instance, if they're vegetarians, it's hard to get enough calcium. So you need to often take Tums, not for the carbonate part, for the part that acts like an antacid, but for the calcium. But if you take too much calcium, it can affect the kidneys. And so it's something just to watch out for. And we, when we have people who have elevated creatinines, we always ask them, what are you taking? Are you taking NSAIDs? Are you taking Tums? The other is just supplements. There's a lot of people taking supplements, and some of these supplements can damage the liver and the kidney. And so, that's something a lot of doctors don't even think of asking. People are self-medicating, and some of the supplements do nothing, but other ones do something. And the problem with the supplements is they're not regulated by the FDA, and the contents can change all the time. And, the patient doesn't know about it, and we don't know about it. So even if it seems safe, it doesn't mean it's going to be safe in perpetuity. So in general, we tell everybody, stop supplements if you can, unless you know what's in them. And plus they come from other countries, and you don't really know what they're doing with these pills. So if you have some underlying, if you're young or if you have nothing going on in your body, most of the time it's not an issue. But if you do have something going on, you don't want to add to that a supplement and assume that that supplement is not affecting what you have going on in your body. So just to opt on the cautious side, it's best not to take any supplements, no matter what your friends tell you.